later. But this is considered more definitive therapy, meaning that if you get through transplant and transplant seems to be working, if you have donor-derived cells, for instance, you're done with your intervention. And one of the pieces that's really important in determining what type of therapy to offer relates to this issue of developmental delay. So, I mean, globally speaking, we think of the Hurler kids as having issues in terms of their developmental and cognitive, or having cognitive impairment, for instance, and the patients with attenuated disease as not having that issue. It's not quite that clean and clear, but that's the bigger picture, how we envision these things in terms of therapy. And just to show what the cognitive decline has looked like for the Hurler kids. So very early in life, the first few months, kids, generally speaking, are quite intact in terms of their cognition, but over time they continuously lose ground. So this is one of the things that is dramatically important in considering treatment, especially for the Hurler population. So enzyme therapy, so these enzyme molecules are quite large, and they don't penetrate into the brain very well. So there's this blood-brain barrier that has evolved to help keep toxic things out of the brain. But unfortunately, in this sort of circumstance, it keeps the treatment essentially from getting to the brain. So that's a limitation in enzyme therapy if you're going to have somebody who's got cognitive impairment and you want to get enzyme into the central nervous system. So the concept with transplant essentially is if you can establish donor-derived cells, so these are normal cells making enzyme, and they can circulate through the body and provide enzyme to the cells that are deficient, that this is a means of slowly, continuously providing enzyme for the life of the patient. So the idea is, again, in terms of this cross-correction, if you have cells going through the bloodstream that are providing a source of enzyme, that the tissues can pick it up and utilize that, and that can help alleviate the storage of glycosaminoglycans. Importantly, though, if you have cells in the brain, the central nervous system, some of these donor-derived cells can make their way into the brain. And these tend to be, we think, microglia-like cells, monocytes, but exactly what proportion of the cells are of what derivation is a bit unclear. But if you can get these cells into the brain, they can also produce enzyme, and they can then deliver enzyme to the cells in the central nervous system. So this is primarily why we still use transplant now, because we have an opportunity to better treat the brain than we have with just enzyme. Now, someone might ask, so if this seems to work for MPS I, does it work for MPS II or does it work for MPS III? And the answer essentially is no. So transplant seems to work better for MPS I than it does for MPS II, than it does for MPS III. And why that is, I don't know. I would love to know. We speculate that maybe for MPS II, you just need to deliver more enzyme than you can get away with for MPS I. And MPS III might just need more enzyme than MPS II does. But we don't have a great way of sorting that out. I mean, presumptively, if you do the transplant in the same way, the same proportion of cells are going to make their way into the central nervous system for all the diseases. But it may be that you just need a small amount of enzyme delivered to help stave off the neurocognitive decline that happens in MPS I, and you just need more for the other diseases. So based on this, so this is from a review article, but if you look at the left side of this, so the recommendations are for the kids that have MPS I that are young, less than 2.5 years of age, which is primarily going to be kids that are diagnosed with Hurler. Those kids go on enzyme and then ultimately would get transplanted. And if you look on the right side, the kids that are older, and so these are either kids that have attenuated disease or maybe Hurler kids that were picked up late and maybe are less likely to benefit from transplant, but those patients may just go on enzyme and stay on enzyme. So there's a big fork in the road here as to what therapy you might offer a patient with MPS I, essentially based on, again, whether they're Hurler patients, they're anticipated to have the neurocognitive defects versus those that aren't. So this is from Julie Eisengart's paper here, but untreated patients with Hurler, unfortunately, most of those patients die by the time they're 10. And there were a number of patients that, after enzyme became available, decided that they didn't want to go through the risks of transplantation and wanted to be just treated with enzyme. And so that's kind of the middle curve here. And as is apparent, those patients don't do as well as those patients that were transplanted. But I think it's also important to recognize that the curves with transplant are not flat. And as we look at some of these patients that are now 20 years out, maybe close to 30 years out, some of these patients, despite having gone through transplant, are still dying of their disease. What exactly they're dying of is still a bit unclear, but we think it's airway issues, cardiopulmonary related problems, but their life expectancy isn't normal having gone through transplant, which is something we need to better understand and recognize and be able to hopefully improve on. So in terms of outcomes, if we're talking about therapies, again, there's another slide that kind of looks at things in a little bit different direction, but if you look at enzyme replacement versus transplant and what do they fix or partially fix, that's the thrust of this. So for instance, the soft tissues such as the liver and spleen, enzyme therapy and transplant both work quite well for. The cognitive piece, as we talked about, enzyme therapy doesn't help very much. And neither of these interventions totally fixes the skeleton. So this is the Kaplan-Meier curve, which is essentially a survival curve. So as transplanters, we reduce a lot of things to Kaplan-Meier curves. But the idea here is that, so this is from a paper that pulled data from a number of different centers that do transplant for Hurler and tried to look at various aspects of the disease and how things were going for these patients. And so the lower curve here, the patients that were transplanted in the 90s, survival was about 50%, but as we improved on the transplant side and had more availability of better donors and whatnot, outcomes have improved. So the key thing of this is that there's significant risks associated with transplant. There's no two ways about it, but we have been able to improve survival of the kids going through transplant for Hurler. Now, within that, this the same data set, but in that group, the median age of transplant was 16.7 months. So this essentially looks at that in that context. So the kids that were older versus the kids that were younger, using that dividing line, they looked at survival, and the key thing here is that the kids that are transplanted earlier have better survival than the kids that are transplanted later. In terms of the cognitive outcomes too, so at least in this analysis, 56.9% of the kids were normal as defined by an IQ of 85 or better at the time of transplant. 16.5% of them were severely affected with very low IQs. But the point I want to make here is that even after transplant, even the kids that have gone through transplant, survived transplant, there is some loss of cognitive ability before they stabilize. So this is a limitation of transplant as well, and Julie and others can kind of expand on this. The boys generally didn't do as well as the girls. If you come in with a low IQ, that's a predisposing factor for a poor outcome. The kids that are older, as you might expect, don't do as well. And then the TBI refers to total body radiation, which is one of the things we used to use to prepare kids for transplant. We don't do that anymore, but in this analysis, TBI, or radiation, didn't help your cognition either. So this is a slide in terms of growth. And Again, this refers back to the skeletal changes that are associated with MPS I. And so there's dotted lines here. The left side is boys, right side is girls, but the dotted lines are the normal growth curve. And then you can see that the darker lines actually are the growth curves for the Hurler kids that have been transplanted. So as you can see, over time, these kids tend to fall off the growth curve despite having gone through transplant and despite having enzyme related from the donor cells. So we're not curing their growth despite having gotten someone through transplant. And so Klain was waxing eloquently about this obviously before, but there's a number of different orthopedic procedures that tend to happen after transplant, and this was the observation in that same group of patients, is that getting through transplant doesn't mean you aren't going to have skeletal related problems. So a number of these kids have knee and hip surgeries, back surgeries, carpal tunnel, cord compression. But if you look at these a little more closely, so this is kind of focusing on carpal tunnel now, they broke the groups apart into the kids that tended to have more enzyme after transplant and kids that had less enzyme after transplant. And if you have more enzyme, it's less likely that you'll need to have carpal tunnel surgery. So enzyme levels end up being important. And they also looked at it in terms of age. So the kids that are older are at higher risk for having to have carpal tunnel surgery. And this same sort of observation was present for a lot of the procedures that were in the prior slide. So one of the things that I kind of keep coming back to and points I really want to make is age is important, enzyme is important in terms of outcomes. So just to kind of wrap up what we were talking about in terms of transplant for MPS I, it's primarily the Hurler kids that we transplant, not the attenuated population. Survival has gotten better, and in the large centers tend to publish their outcomes, and it's 85 to 90% survival now. And not to kind of besmirch my other transplant colleagues, but I'm afraid the large centers that have a lot of experience publishing very good outcomes can be a little bit misleading. Because the transplanters tend to say, well, we have the same chemotherapy that these large centers do. We have the same access to donors that these other centers do. So, why shuttle them to the centers that are the larger centers have more experience? But I think it's misleading because treating a Hurler kid as one is not the same thing as treating a leukemic who's one. I mean, there's airway issues, there's cardiac issues. These kids get in trouble in different ways than the leukemics do. So I think we need to kind of separate out which centers, have sufficient experience to be treating the patients with transplant. So my 2 cents on that. So what can we do to make things better? So as I was alluding to, age seems to matter. Can we identify the patients earlier, intervene earlier, because that may have great advantage. I pulled this off the website last night, and if I counted this correctly, there's 34 states that are now screening for MPS I, which is actually a little bit more than I thought. I thought it was kind of more 28, 29. But this is important, and as people might understand, it's kind of evolving and new states are being added all the time. But being able to pick up these kids at birth, essentially, and intervene early is going to make a huge difference. So this is a major step forward, I think, in the treatment of kids with MPS I and other diseases as well. So in terms of the enzyme and being able to deliver more enzyme, so, I mean, we've refined transplant a lot over the last 20, 30 years. We are more precise in terms of our chemotherapy. We can find better donors. We have better supportive care. So we can get kids through transplant better than we could 20 or 30 years ago. But if somebody 30 years ago went through transplant and they're fully engrafted, meaning all the cells in the blood are donor, they aren't necessarily doing any better than the patients that we're transplanting now. in terms of efficacy of treatment. So if we can deliver more enzyme, that would be advantageous as well. So this is just from a paper that was looking at gene therapy as an approach in the mice. And so this is a lentiviral-based approach. So lentiviruses are essentially based on the AIDS virus, and they remove all the pieces that are related to the normal AIDS virus and replace it with the ability to deliver enzyme, for instance. But this is looking at the outcomes in the mice. And just a couple points I wanted to make in regards to this. So in these two figures, the black dots are the untreated Hurler mice, or IDUA deficient mice. The normal mice are the blue dots. And then if you look at the mice that are transplanted, those are the green dots. But the mice that were treated with gene therapy are the orange dots. And so on the left side is how much enzyme is present in the blood. And as you can see, you can deliver a lot more enzyme with gene therapy than you can with transplant. So this is on that axis, that y-axis, that's actually a log scale. So it's a large amount of enzyme we're talking about. And then on the right side, similar, they're actually looking at the blood cells in the mice that have been transplanted, and there's both 4 weeks and 6 months in terms of those orange dots there. And 6 months is a pretty long time for a mouse. So the idea is that this is a stable type of therapy. So one of the other directions to look at it is what's the size of the lysosomes in these mice. And so Joe and had shown before that with the accumulation of storage material that you get in these cells can be huge. So this is addressing it from that standpoint. The black bars are the untreated IDUA deficient mice or Hurler mice. The transplanted ones are green bars, and then the orange are the gene therapy bars. And as you can see, transplant makes a difference in some of these various organs clearly, but gene therapy better corrects the lysosomal size than transplant does. So this is from a presentation from the World Meeting back in February, looking at a pilot of gene therapy for the MPS I kids. So this was done in Milan, and there were 8 kids on this pilot study. There's chemotherapy associated with this as well, fludarabine and busulfan. Rituximab is to help get rid of some of the B cells, but then the kids are reinfused with their own corrected cells as opposed to using somebody else's cells. And this is essentially kind of how this works. So the kids are identified. They have to have kind of a big IV placed. There's a procedure called apheresis where you take blood out and it circulates through a machine that spins out the cells of the right density, the cells that we want, and the blood goes back in. And that's a 4 to 6 hour procedure. The idea is to get the kids' own blood stem cells. Those cells are then sent for manufacturing, and you use the virus that was designed to express the IDUA gene within the cells. The cells are frozen down, and there's a lot of quality control pieces that they do to make sure the procedure went well and that there's no infectious complications and those kinds of things. And that takes a few weeks, close to a month. And then when you get word that the procedure went well, the transduction procedure, engineering procedure, then bring the kids back. They still need to get chemotherapy because you need to get rid of the cells in the bone marrow that are producing blood so that the corrected cells can take over. And then you follow the kids afterwards to see how they're doing. So this is from a paper in the New England Journal from November of last year, and just looking at some of the experience. And again, a small number of patients, there's only 8 kids here, and relatively short follow-up, so this is really only out to 2 years. But this is a figure looking at enzyme present in the blood, and as you can see, that blue bar there is the normal amount of enzyme, so virtually all these kids have more enzyme in their blood than would be considered normal. And this is kind of the flip side, looking at the ability to clear the glycosaminoglycans from these are urine GAG studies. But as you can see, that over a period of a couple months, the GAGs come down and are essentially normal. And this is looking at growth. So I was showing the growth curves before with transplant and how the growth generally tends to fall off over a period of years. So this is looking at months. So again, the experience is relatively recent, and we don't have a really long-term follow-up here. So I don't want to read too much into this, but I'd say it's encouraging that the growth seems to be preserved. So there's other ways of delivering enzyme besides the lentivirus-based approach. So that's what we call ex vivo, meaning you get the cells from the kid, the blood stem cells from the kid. You engineer them essentially in the laboratory. They get chemotherapy, and then they get their cells reinfused. So this is a different approach, different virus. It's called adeno-associated virus, or AAV. But in this circumstance, you deliver the virus directly into the patient. And the idea here is to help get the virus into the central nervous system and alleviate the neurocognitive problems. So they target the cisterna magna, which is a collection of spinal fluid in the back of the brain. And the idea is that that virus will then, through the spinal fluid, distribute itself into the brain and express enzyme. So this is the Regenix Bio approach. These guys are going to be talking a bit later today, so we'll provide some data. The Orchard Therapeutics guys are going to talk a little bit too. I don't know how much data they're going to show, but are going to talk a little bit about the Milan-based studies as well. And this is a new protocol that's actually is now open. So this uses a different approach. So this is a non-viral approach. This uses the Sleeping Beauty transposon system, which is a DNA-based means of delivering and expressing the enzyme. So it doesn't rely on a virus. But this was engineered to target B cells. The promoter is a B cell specific promoter. And in this circumstance, just the B cells are pulled out. Still this kind of apheresis procedure that we talked about before. And then the transposons are introduced into the cells. And that's actually done through an electroporation procedure. So essentially you have the B cells, you expose them to an electric current, and the DNA can make its way into the cells and express enzyme. This is some of the mouse studies there, and just showing that there's a dose response in terms of how many cells you deliver and how much enzyme is present. So this was initially proposed to treat the kids that were post-transplant and to help deliver more enzyme and potentially get better outcomes in the kids. The FDA wanted to start with adults, and so the protocol got rewritten essentially to target that. So it's now open essentially as of last week. So if there's attenuated patients with MPS I that are adults that are interested in some other therapeutic options besides staying on enzyme, and you wouldn't have to come off enzyme to get treated for this, but this will be an opportunity. And so if anybody's interested, let me know, because the protocol is open as of last week. So I'm going to stop there. I should mention actually that I didn't talk about all the things that are going to be available for MPS I. So the Nolly group is going to talk a little later, and the JCR group is going to talk a little later. So they're doing essentially second-generation enzymes that are engineered to help get into the central nervous system better. And so I encourage people to see what their presentations look like as well. But from our standpoint, it's great to have other things that are now going to be able to at least be attested for the MPS I patients, because we've been doing the same thing for the last 20 years, essentially. And we know it's insufficient. I've been doing transplant for 30 years, but kids still die, and kids have tons of complications, and the risks are still high, and it doesn't cure anybody. So we need other things to do, and I don't know if any of these things are going to be curative, but having the opportunity to consider treating patients with something that might be better is very encouraging. So I'll stop there. Go over here.
Yes, come over here, and we're going to invite our other speakers to join us on the stage. Do we have microphones for our speakers? So while we're getting this set up, if you'd be thinking of your questions, we've got quite a brain trust here of MPS experts and experience, and this is an opportunity that we don't want to miss. So we're going to give them just a minute to get set up here. So we have about a little over 20 minutes for this before our next talk. Are we going to use this mic for questions?
I can start with a question, Steve.
Okay.
First one will be for Paul, then I have a couple for Clayne. Joe may chime in. We were recently looking at an MPS 1 patient for a clinical trial, and it was the L490P genotype. And if you look at Lauren's paper, now they classify it as attenuated. Then you look back at a series from Simon Jones with 5 older patients and 3 younger patients, and the 5 older were on enzyme. They all had significant neurologic deficit. The younger transplant much shorter term. They were the younger SIBs. But and Joe, I think, was an author on the paper also. Using just 2 categories, you put people in attenuated, you sort of take them out of the transplant realm, and yet there seems to be very significant disease. Is this too crude a classification? It'll affect
You're asking me this.
you and Joe, not Clayne. We'll spare Clayne.
Well, Clayne can answer if he wants. Yeah, so it's crude, trying to pigeonhole patients into a Hurler category or an attenuated category and pretend like those are really distinct, because obviously there's a continuum there. At least in the US, the decisions, I think, are, so one can kind of argue what's better as therapy, enzyme therapy or transplant, and I think biochemically and some other categories, you may say transplant may actually better treat the disease than enzyme therapy does, but we're weighing that against the risks. And so, if you have someone that you don't clearly know is going to have neurocognitive progression, is it worth taking a 10-15% chance that they're going to die going through the transplant procedure? And so those are the things that we're trying to weigh. So we're not, transplant's expensive, but it's not as expensive as enzymes. So we're kind of taking the costs off the table, and we're mostly making decisions based on risk. Now, and I didn't really go into this in the presentation, but if you do an autologous transplant, meaning you give the kids back their own cells, as opposed to doing an allogeneic transplant, where you have to worry about graft versus host disease and rejection and all these other kinds of things, the risk is much lower. It's probably 1 or 2% in terms of death going through transplant. And so, I don't know, if it looks like 5 years from now or 7 years from now, or whatever it is, we have a lot more information that type of approach, even taking the efficacy piece off the table, if that's much safer, is that going to modify how we're going to offer therapy? I don't know, it's purely speculative on my part.
I think the key really is this issue that transplantation is beneficial, but as Paul said, it is not curative by any means, and there's a lot of issues. And it's really expressing sort of marginal. To me, this new data with the MPS1 ex vivo gene therapy, using the lentivirus, where they're making 2 to 5-fold or more greater circulating enzyme at all times, appears to be somewhat better in terms of outcomes. So it shows that we need to deliver more enzyme. And if you could lower the risk of transplantation to a few percent, then potentially anybody could potentially benefit from that, and even the attenuated. So I've always said the risk of transplantation, as Paul said, really precludes a lot of these milder affected patients, but they have issues. So, doing it earlier with much more enzyme, we may see a dramatic difference. Remember, these patients in the ex vivo MPS1 paper are all 2 years or so. They're older, most of them are older, not 6 months or less. And so if we treat patients with under 6 months, under 4 months, with much higher levels of circulating enzyme long term, we may see a very different outcome. And it may impact a lot of the MPSs. The problem is that it's much more challenging to take cells out, put them through a factory procedure, and then put them back in. That's a much more basically individualized medicine approach.
I might just add a little bit on this too, is that, so we've been doing newborn screening for a while. It was 2016 actually when it went through the RUS. But we don't have a lot of data in terms of transplanting kids at 4 months versus 16 months and how much difference that really makes. I can tell you that it doesn't fix their bones, because certainly a number of these patients that have gone through transplant at 4 or 5 months of age still have significant kyphosis and hip disease and those kinds of things. And maybe Julie wants to weigh in on the neurocognitive side. I think from that standpoint, we may make a huge difference if we can intervene before these kids actually start to have some cognitive decline. But we don't have a lot of that data to help us sort that out yet.
I'm Kim McClelland. My son is Lauren, who is 24, has gone through 2 transplants and then ended up with having to have a boost of donor marrow. I was wondering, are y'all seeing any renal disease in these patients? Because we now have polycystic kidneys.
MPS1. MPS1?
Yes.
Okay.
Do you want to?
Yeah.
So I don't ordinarily think of transplant as exacerbating polycystic kidneys. Sort of, I generally think of that as a separate related issue. I haven't really heard about it as a manifestation of MPS1, but.
No, I'm not aware of that an issue, but again, we have to realize that a lot of our patients with one genetic disorder have a risk for a second genetic disorder that may be not obvious when the first one. And so it'd be worth exploring that, whether there's other genetic risk factors for polycystic kidneys in your particular family.
Hi, good morning. My name is Kevin, and my son is 25 with mucolipidosis. And probably for Dr. White, for spinal fusions, why do they fail? And I guess can you just talk about the reasons why? Yeah, because it seems like there's always a touch-up going on after you get your first one.
Can you hear me? Yeah. Okay. So yeah, I mean, spinal fusions can fail for multiple reasons. There's sort of short-term complications and there's long-term complications. So short-term, things that can go wrong, or you can have neurologic problems, deficits that we've kind of already elaborated on in our talks earlier. Infection is common, and the more compromised your overall health is, then the more likely you are to have an infection. So those are sort of early failure problems. In general, my feeling is that bones heal just fine in MPS, but spinal fusion in general, the older you are, then the more likely a fusion is to not take. The biology just, young kids, whether they have MPS or don't have MPS, just heal better in general. And so a failure of the fusion to heal. So the way I like to think about when we do a fusion, what that means, and I've sort of brushed by this earlier, is that to do the deformity correction, we put instrumentation in, and then we use that instrumentation to affect a deformity correction, and then we put bone graft over that. And that bone graft then becomes incorporated, so that if you go back a year later, there should be a sheet of bone across the back that fuses all of the vertebral bodies together. If you do a single level fusion for a 50 or 60-year-old for degenerative disc disease, they have a 10% failure rate just from not fusing. Whereas I can do a 10-level fusion on a 13-year-old, and there's probably like less than 1% of all of those fusions not taking. So there's the biology issue there. And so you have the rebar, which is instrumentation. You have the fusion, which is the cement, and that's what holds your spine straight. But it can be mechanical, it can be biological, and there's a lot of factors that play into that.
Clayne, ML2 and 3 bones are similar to MPS bones in terms of handling hardware or not?
That's a good question. I mean, you would think that, I haven't taken care of any ML kids myself, so would take that for what it's worth. But looking at them radiographically, they seem to be pretty similar. They tend to be smaller. They have smaller bones, so you need smaller instrumentation. And when you have smaller instrumentation, it's not as strong. So it's not as quite mechanically sound as the instrumentation we often use. So and they're just trickier deformities to deal with. So.
Hi, my name's Roy Tinker, and I'm a pediatric genetics resident at Vanderbilt. This is probably more a question for Joe. Given your experience of dealing with MPS, what's your advice for kind of a general non-metabolic geneticist to kind of, when we see patients in clinic who are just not quite normal, to kind of speed up these patients' diagnostic odyssey so that we can actually loop them into kind of clinical trials and enzyme replacement therapy earlier? I hope this question becomes academic as we kind of disseminate newborn screening for MPS, but obviously we're not in that position yet.
But as you appreciate, the key is really awareness, to think about these disorders, to be aware there's treatment out there, and then if you have an individual who you suspect may have an MPS or other lysosomal storage diseases, do the testing, do the storage, do the urine gags, or these days there's gene panels now that are available to really help you sort of identify if you're not sure what class of storage. But again, I think the diagnosis is getting much easier for geneticists because we have gene panels and people don't have to think as much. You think that's a storage, do the panel. That's unfortunate. The patient's not examined as much, but where historically before gene panels we had to do a lot more. But I think with newborn screening is going to dramatically change, because the problem is that the time a referral for an MPS patient comes to my clinic, as I said earlier, it's pretty obvious. I can walk through a big waiting area. Oh yeah, that's my patient. Have never seen them before, and so it's pretty obvious to try to. The key is that awareness, and awareness is one thing, but newborn screening is going to really be the key for these disorders. There's a nice study out of the Netherlands where they did a lot of awareness over 10 years, and it didn't change at all when MPS 1 patients were diagnosed.
Is there a decent yield for exomes on MPS as opposed to just a panel-based approach?
Sure, you're going to pick them up because it's because these are very recognized. You're going to pick up a lot of other things on exomes. So sometimes doing a panel-specific sequence can be better, because if you do exomes, you're going to find a lot of so-called variants of unknown significance, the VUSs, which genetic counselors hate to see because it just really complicates their life.
So to build on that, I want to add a question here. If with newborn screening going on, and we know kids are being diagnosed and parents are having to make a decision, do they do the transplant or do they enter a gene therapy trial? What are your thoughts on how a parent would navigate that question?
For MPS 1, I think it's relatively straightforward, since we have a much better sort of genotype-phenotype correlation that we can sort of predict who's going to have Hurler syndrome. And if you make that diagnosis, then to me, then it's pretty clear, even though transplant's not perfect, it's far better than the untreated state. So that's, I think, is, but again, as Dr. Burton yesterday alluded to, we're going to be picking up milder and milder patients with newborn screening, and it's not always clear who you should intervene in. And just to send a patient who gets diagnosed with MPS I without knowing what their phenotype may be to transplant is not correct. It's not a good decision, and you may want to wait a little bit and watch. So yes, newborn screening is going to be fantastic to improve outcome, but there's a lot of unknowns of severity, and we do a poor job yet of predicting based on genotype for MPS II yet. We're going to have challenges who we recommend for treatment. Transplantation is a whole other issue for MPS II.
But if the parents do want to treat, the selection between transplantation or gene therapy, entering a gene therapy trial, that's what I wanted to get
It really depends on what trial, because again, there's only one current trial, for example, for MPS II for gene therapy. There's currently another one for MPS I, but there will be more trials in the future. It's going to be a changing landscape. I think it has to be an individualized decision. One can't I can't say we do this and this here, because it's depending on the age, the severity, the family history, there's lots of other issues.
It
so
may
just-
get kind of confusing because different institutions may take different mindsets in terms of how to, if you find that as a Hurler patient, you've got allotransplant available versus gene therapy, how are you going to decide what to offer the families or how to counsel the families? And, again, where you are might make a bit of a difference. So for instance, just from my standpoint, if we have auto gene therapy available, I'm interested in being able to explore that. I don't know if it's going to be better than transplant or not. Obviously it's very early, but we've been doing transplants since the 80s for MPS I, and we sort of know what the limitations of transplant are. And being able to get more data with a new type of therapy only makes sense to me.
Anyone else want to weigh in?
For that, there's more than one type of gene therapy, so that's, I think, the key issue.
Yeah, and sometimes if you have a clear genotype, then I think transplant makes sense. For us, we've had one identified so far, and it was not an obvious genotype that would be Hurler. So, we start that patient on enzyme replacement therapy right away, and then we're watching that kid slowly. But, the other thing about clinical trials is they have very strict inclusion-exclusion criteria. So it's not like, oh, okay, well, I'll just go join a trial. But so that's not necessarily going to be available. And they usually start with older patients and not infants for safety reasons. So I don't know where we are with that, but it seems like that's probably a little bit ways off still.
My understanding is it is available.
Okay.
There's a parent here who made that decision, and
Be a little more specific, what's available, Steve, for the audience?
Gene therapy for a young
Ex vivo gene therapy?
I can't speak to that. I'm
Well,
sorry.
No,
then
so
you can't say things. We need to be specific. Just saying gene therapy is not enough these days.
I think the Regenix Bio, those guys are talking later, so ask them, but I think the Regenix Bio AAV into the cisterna magna protocol is still open and they have both MPS I and MPS II. I was just talking about MPS I, but I think that protocol is still open. The lentiviral one is not, but I think it's fair to say that there's interest in trying to get that off the ground. So, but it's not available now.
Okay.
My sense, this is a very personal decision, and the best you can do is to lay out what data is available on both sides. We have much more on the transplant side, but try to describe what's been presented. It may be published. There may be preclinical data that you can refer back to. There may be, it works more data in the MPS II, for instance, with Regenix than MPS I. So you fall back. It's not a perfect system. And on the other hand, you're weighing a mortality, which Paul describes as 10 to 15%, and then it becomes very much a parent decision. Which way do I go? And we've had Hurler patients who have elected not to be transplanted. They wanted enzyme and they didn't want the risk of death, and it almost came down to that rather than the benefit that they could get and the long-term effect of not doing the transplants. So I think the parents are going to have to make
And
the final decision.
there's other issues too, in that, I mean, the FDA is going to want us to follow patients on gene therapy for 15 years because they want to see what the long-term follow-up looks like. So that's going to be a requirement, essentially. If you're going to go on a gene therapy study, is you're going to have to go back and be seen and monitored in an ongoing way for that period of time. Like maybe that'll change down the road, but that's currently what they want people to do, is be monitored for 15 years.
Steve, there's a lady in the back there. Okay.
My name is Alicia Bowley. My son Jacob has MPS 1 Hurler. He was diagnosed at 3 and transplanted at Duke at 3.5.
Months or years?
Years, 3 years. So he's 2 years post-transplant now. He's making a normal enzyme amount. He's still greater than 98% donor cells. Has there been any evidence or data or study to show that ERT started now would show like any improvement or any help, because he's never received ERT?
Well, that's a complicated question. Some of the data that we were showing and discussing suggests that the more enzyme you can deliver, the better you may do. But that's not been studied. So there are some of our patients that have gone through transplant. Generally, we stop it after a couple months after transplant when they're fully engrafted and say, okay, you've got enzyme present. But some of the families have decided to stay on enzyme, and maybe on enzyme for 4, 6, 8 years after transplant. And we haven't really studied formally whether they're doing any differently than the patients that weren't. But a lot of the families recognize that even having gone through transplant, there's a good risk that my son or daughter is going to need hip surgery and back surgery and all these other kinds of things. And whatever we can do to potentially decrease that risk, even though there's not good data to support it. I mean, I think that's kind of their mindset. Well, right. So, and I just wanted to mention really quickly too. So we look in the blood to find out how much enzyme is there because it's easy, but it doesn't tell you how much enzyme is in the heart or in the brain or the kidney, for that matter. So how much enzyme is actually in the target organs, you can't get out of looking at, because you're just looking at donor cells when you're doing blood, right? So you'd expect it to be 100%. But maybe I shouldn't say this, but I kind of will anyway. So in the old days when Bill Crivet was doing some of these things, who was my mentor, so, they'd get liver biopsies and these other, and actually look to see how much enzyme. We don't do that stuff anymore, but that's the way you find out, right? You can do it in the mice, clearly, but you can't stick needles in all the organs of the kids and find out where things are. And that kind of gets back to this other question that we were talking about before, is we don't know how much enzyme we're delivering to the brain, and the only way you'd figure that out, really, is to be able to get tissue, and obviously we don't do that. So kind of gets back to this question about how many cells from the donor are actually making their way into the brain, and how much enzyme are they delivering. And again, you can look in the mice because you can take the brains out and do whatever you want, but you can't do that on the kids. So, that's one of the limitations we have.
But one of the issues that enzyme does or doesn't do is the same problem with transplant. So they have similar issues in terms of, I think I showed it, things like that are not responsive to the bone disease. Neither one responds to to treat the bone disease for MPS 1, for example. And so it's not clear to me whether giving additional enzyme makes any difference at all if you're fully engrafted. So if you're fully engrafted, I think it's really questionable whether enzyme it clearly hasn't been shown to be beneficial.
Yeah, we've got one last question.
Am I able to ask a question online?
Therapy so far that we came up with. My question is cord blood longer affecting than bone marrow donor?
In terms of how much enzyme is delivered or those types of things?
Well, I hear a lot of people say that they've had to do more than one bone marrow transplant. So I'm just curious, is cord blood better for that. We have a 4-month-old that was diagnosed at, via newborn screening. And so we're just trying to figure out what's the best thing. And until we came here, no one even mentioned gene therapy. So we're kind of like, you know, which way are we supposed to go?
There are some advantages to cord blood. You can do it quicker because the cells are already frozen down and ready to go. I mean, they're in liquid nitrogen somewhere. So if you find a cord blood and you make sure the match looks like it's good, you can move forward really fast. If you do an unrelated donor, so you maybe you got somebody in Berlin who's going to donate, going through that process of identifying the donor, making sure the donor is healthy, actually setting up a time to do the harvest, all that stuff, that takes significantly longer. At the end of the day, I mean, we looked relatively recently, Troy London, our group, looked at this, but some of the kids that were out years after transplant and looked at how much enzyme was there, for instance, with the cord blood and the unrelated donors, and it wasn't really any different. So it's kind of a matter of what's your best choice in your donors, and so you have to look at what your best match is for the cord blood. At least that's be our approach. What's your best match in the cord blood? What's the best match in the unrelated donors, and sort it out from there. But
And for
I don't know if I'm answering your question, but
for a 4-month-old, there's really no eligible gene therapy trials yet, to my knowledge.
I don't think so. But
Okay, let's thank our speakers for the Q&A.
Am I able to ask a question online?
Yeah, y'all got to come down. Amy, do you want to go ahead? She's already set up? Okay.
Ooh.
I got to introduce you real quick.
Oh, sorry.
No, that's right. Okay, our last speaker for this session is on the topic of functional outcomes in MPS, neurocognitive function and beyond, and it's Dr. Julie Eisengart, and she's an associate professor of pediatrics at the University of Minnesota Medical School and director of the neurodevelopmental program in rare diseases. And as a pediatric neuropsychologist, she specializes in rare childhood neurodegenerative disorders, evaluating functional outcomes of disease in response to therapy. Her research has focused on the MPS disorders with the goal of predicting outcomes and improving supportive planning. She's been heavily involved in examining outcomes of early diagnosis, newborn screening, and novel therapies. She's served as a principal co-investigator and research mentor on a number of observational studies and clinical trials for MPS. And presently, she serves as the associate chair of the Scientific Advisory Board for the National MPS Society, so we appreciate that. Welcome, Julie.
Thank you. I hope I can make this work because I have a lot of animation on this, okay. So thank you so much to the Society for inviting me and for all of you who have taught me so much. So today I'm going to be talking about what I mean by function. There's often the word neurocognitive, and there's so much more to someone's function, so I'll be talking about that, how we assess it, and then of course impacts of various functional concerns on the affected person and the family. So I want to move broader than just neurocognitive function. So neurocognitive is, sometimes people think of emerging developmental ability or intellectual ability. There are a lot of really important other functions: communication, attention, movement, behavior. So I'll touch upon those. We talk so much about how complex MPS is, all the MPS types, and so when we think about function, it's so much more than how someone does in an exam room, how they perform on a cognitive test. There are a lot of things that affect how someone's functioning, and we really keep this in mind a lot. Things like sleep. things like the emotional experience. You know, how did my surgery go? How did that feel to me? Or what's my next surgery going to be? What's my next complication going to be? Those sorts of stresses can affect how someone's doing day to day. All of us who face stress, that can be distracting. It can tax how we're doing things. This also happens across MPS types. Skeletal effects, certainly this has been described a lot, but those can affect things like learning how to write and learning how to, engage with the environment. Sensory needs, how you learn language, how you communicate, how you see things, can really affect how you function. So how do we assess function? It began most meticulously when examining outcomes of treatments for some of the MPS types. One of the earliest types to be involved in examining outcomes was Hurler syndrome, to see if bone marrow transplant was having a sustained effect on the neurodegenerative course of Hurler syndrome. So here, Dr. Orchard had already put this up, but to show it in the way that we look at these graphs, we compare age to the cognitive score. In this case, it's something called the Mental Development Index. This is quite a long time ago. I want to draw your attention to this line of dots at the bottom. That's the floor of the test. That's something that we have learned to get around, and I'll be talking about that shortly. But this is how assessments sort of began in terms of the systematic tracking of cognitive function over time. One of the, it's really important for things like identifying the course, the functional course of the condition, and certainly for identifying response to interventions, clinical trials by all means, standard of care by all means, but also supportive therapies. So here's a picture that some of you might be familiar with, but there was an international consensus on what are the best ways to measure function in MPS. Here's just one of them that was agreed upon first in 2016 and then updated in 2020. And this is for people who are infant or toddler age or functioning within the realm of the infant and toddler level. And it's a test that involves various toys and manipulatives and seeing what the person can do in the environment. And so here's a little precious friend who's enjoying the test quite a bit. There are various sort of block stacking techniques that we sort of quantify and see how she's progressing along. But when we think about these tests, and this is something we emphasize a lot, these tests were not designed for people with MPS, right? They were designed for most often typically developing individuals who do not have medical complexity in their experience. So what we work really hard to do and champion quite a bit is that we have to select tests that meet the needs and function of the person, and we have to give the tests in ways that meet the needs and function of the person. So when we look at this example, I think this is grabbed from the publisher's website. So here's this child sitting facing the examiner in an unaccommodated seat with an unaccommodated pencil, and this is not always the type of fit that we expect for someone with MPS. And so we have to adjust the way that we administer these tests. Now, let me go back here. Sorry. So when we're training people on how to do this, and when we're giving these tests ourselves, we really think very carefully about the effects of MPS on engagement in the test. And we interpret performance based on how someone might be feeling, how the test might be received by them. We think about things like other appointments. Okay, so people with MPS often take longer to come down from having their eyes dilated. So if there's an ophtho appointment the day before, and then they come to my test where I'm asking them to visually discriminate between things, then their performance might not be reflecting their true performance on that test because their vision has changed. We think about these things for sedation. When people come for their multidisciplinary, their week of visits, we make sure that sedation has happened either 2 days before they come to be tested with us or after they're tested by us, because sedation can also affect these things. We're really careful about interpreting the appearance of non-compliance on our tests, because most often what it can mean is that the test in some way, shape, or form is not in that moment meeting the function and needs of the child or the person who's taking the test. There was a computer test I was doing, and there was a person with attenuated MPS 1, an adult, who had really gotten some poor performance on the test and said to me, if you make me reach up to touch that computer board again, to push the button, I'm never coming back to take this test, because it was all about the shoulder discomfort in pushing the button. It had nothing to do with the performance on the test. But these are the kinds of really important collaborative conversations we're having to understand how best to meet the needs of an individual who's taking these tests. So if there's frustration during the test because a child didn't understand and it's a child who is nonverbal, is it really that this child has behavior challenges, or is that we've created a situation that's really frustrating and hard to understand? So we have to think about those things. The consensus conference that I had mentioned earlier with the updated recommendations involves not just test lists, but also recommendations for people to read on what are the things we need to do to be testing function and testing capabilities. Here's a whole list that I needn't read to you, but some examples include, there are some MPS types that involve very slowed processing. They get to the answer, but it takes a lot longer. So an example is, I'll give a question number 1, don't get an answer. Question 2, question 3, question 4, I get an answer to question number 1, because that's how long the processing took. And you have to know MPS, and you have to know what you're doing so that you can give credit to reflect that this person actually knew the answer and was able to provide a response, just not in the typical amount of time, which is okay. So when we give these tests, there are all kinds of scores, and we have a lot of conversations about scores. And for families who are involved in trials or families who have been treated and are, accessing testing, there's a lot of discussion about, well, what did my child score on the test? So I just want to go over them briefly. Raw scores mean literally how many items did this person get correct on the test. Age equivalents mean that you take that score, how many points did the person earn, and you just look up in a table in the test book. What does that score convert to? What's the mental age? So 10 points on this test is an age equivalent of, a 1.5-year-old. Then there are the age norm scores. Those are things like IQ scores or the standard score, the cognitive score for the test. Age norm scores are tricky because what they actually reflect is where someone stands relative to the typical curve of development. And they don't actually mean something about how a child is developing forward or not developing forward. So I've shown this before, but I want to show it again for illustration purposes. Here's an example of a child with Hurler syndrome who went through transplant. We'll just focus on the cognitive at the top. The scaled score is the age normed score here. The average range is 7 to 13. So in the beginning, this child has a score of 9, which is in the average range before transplant. 6 months after transplant, the score goes down to 4. A year after transplant, the score goes down to 3. So by these scores, it looks like this child is having a Hurler-related decline, and that's actually not true. If we cover those up and we look at the raw score, remember this is how many items did the child get correct on the test, we see in this top row that every single time the child earned more points. So there's actually progress here that is obscured by this scaled score or the standard score. So what is really important is that we think of these age reference scores not like, how forward is my child going, but rather their speed of development. So, if we look at this illustration, and especially if I cover up the blue car, that car is actually going forward, right? It's just going forward slower than others. And that is a visual that's a visual demonstration of how these declining scores can look like someone's losing when in fact they're just going a little bit slower than everyone else. So next I want to show some of the plots we've been using more recently. Rather than these standard scores, which can really make someone look like they're declining when they're not, we're comparing this mental age to chronological age. A lot of times what we're trying to do is figure out when disease is having its greatest impact on development. This actually is one of the reasons that one of the reasons we plot this way is because it helps identify what are some optimal times to intervene by. So in this hypothetical illustration, this is not a real disease, but if we look at this purple line here, this is typical development. So this is where the chronological age meets the mental age, they're equivalent. This black line here is the hypothetical vector of disease effect, so the neurodegenerative process pulling down. In this illustration at age 4 is when the disease effect really sort of accumulates and starts pulling this child away from the normal curve. This period right here, where this child is still gaining skills, but just slower, especially in rare disease where it's just not obvious and it's not on people's radar, makes it really hard to detect that there's a neurodegenerative process going on because everyone's noticing that the child is still gaining, right? Now, in that situation, intervening there while the child is still gaining tends to be a time when, if the intervention is a successful one, development can resume. The question becomes, what happens if you intervene in a place where some regression has begun to occur? The question is really why there's regression. There are all different kinds of things that can influence why a child is coming across as losing skills. Hearing loss, for example, all kinds of multi-system effects can create the appearance of loss that may or may not be brain-based. So it's really a question of what happens when there's intervention at this point, and I would say that's a little bit more challenging to just say universally what will occur. Here are some natural history studies that we recently assembled to look at. This was a gathering of 3 different studies for neuronopathic Hunter syndrome, and here's a gathering of multiple studies for MPS IIIA Sanfilippo syndrome. And in both of these, you can see these curves where there's the development, the slowing down in development, and the decline. Both neuronopathic Hunter syndrome and Sanfilippo syndrome do have extended periods of, in the untreated natural history, have extended periods of very low functioning that until now, I would say, or still, it becomes very challenging to show what these individuals are doing, what they're able to do. And so what we've begun to champion is a new method for evaluating function that's different from the IQ scores, different from the age equivalents, because as you see, even these age equivalents are showing kind of bumping around pretty low. What we're beginning to focus on is this concept of personability scores. So it's much more about the individual's capabilities and what they are doing, what they're achieving, much more so than how many points they're earning on the test, and more than age equivalents, which can be sort of blurry sometimes and sort of misleading. So they're also known as growth score value, or GSV. And this is pretty new for the rare disease, neurodegenerative rare disease space, but it's been around for decades, and it's been used in a lot of other neurodevelopmental conditions. It's been championed as something that's useful for people who have, are within the neurodiversity spectrum. And we have, our preliminary looks are really promising for this. So let me explain or just sort of illustrate why personability scores are a really important next step. So if you'll see here, if I don't talk too much in the, let's see here. So it's sort of low at the bottom and some of the transcriptions covering it, but let me just explain some of them. So if we look at these two different requirements within the Bailey, for example, and the question is really, what do you think is the bigger step forward when a child does one piece to the next piece? So a child goes from showing evidence that they recognize their caregiver, an alert, like a face of recognition, to displaying some sort of reaction when the caregiver goes out of sight, right? Kind of looking, maybe showing a little tension, right? So what ability leap does that take? Versus a child who picks up a block, or the block is on a washcloth and realizes that they have to pull the washcloth to them to pick up the block. It's really hard to say, like, what's the difference between those two scenarios? How much more skill does it take for the person to recognize a caregiver and show some distress at the caregiver leaving versus someone to pick up a block or yank a washcloth? And so what a personability score does actually is create sort of equal, it's a nonlinear transformation. It's some sort of fancy to statistical transformation, but for our purposes, what's really important is that it helps reflect the actual differences in ability spanning those two types of things. So in the first scenario, it takes 6 more points on the Bailey to make that difference between recognizing a caregiver and showing some sort of recognition that the caregiver's gone away. With the block scenario, it's 1 more point. And I would argue that that's not perfectly clearly the magnitude of difference between those two scenarios. What a personability score does is it takes away this 6 points, 1 points, transforms it to a new score that really helps us understand the person abilities. So hopefully this next table will help illustrate the point further. We have 2 children here, the top grayish, tannish, and the bottom bluish. The top one is a child who was diagnosed at birth because of an older sibling. The bottom child is somebody who was diagnosed clinically. And we have time 1 and time 2 assessments on the Bailey. If we look at the difference in raw score points, so from time 1 to time 2, the littlest baby got 16 more points on the Bailey. Same thing actually with the older infant. Between time 1 and time 2, also 16 points difference. Those 2 sets of 16 points actually translate to very different advances in skills. They're not the same. And if we just kind of skip right over to the GSVs, what we see is that for that little baby to earn 16 more points, by the way, this is also conveniently the same time span, 5.5 months. So for that little baby to earn 16 more points in 5.5 months, took an ability gain of 100 points on this new scale. For the older infant, to earn those 16 more points, took an ability gain of about half that. So this actually helps us. There are a lot of times when, meeting with families and we say things like, your child earned 3 more points than last time, and this actually adds a lot more meaning to that than just saying there are 3 more points, because sometimes those 3 more points mean a lot more than 3 more points. There was a family who I met with recently whose child had been in speech language therapy for quite some time, for the past year, and got 3 more points in the cognitive, 3 more points on language, and on the language, the ability gain was a 78. with that 3-point gain, which gave some really important feedback about the effectiveness of the speech-language therapy intervention. Whereas the cognitive 3-point gain had an ability gain of, I think, like 25 points. So it's some really important feedback for us that we're focusing on more and more. This should also give an example, or an illustration rather, of these personability scores. Here is an image from my colleague Heather Adams from the Batten Disease Center at Rochester. And this is a subset from a study she's doing of children with CLN3 Batten disease. So if we look here, this is the Vineland. Some of you might be familiar with it. It's an observer-reported outcome. That means that parents fill out the frequency that they're observing their child or young adult engaging in independent behaviors. So if we first look at the scores from this, using the V-scale score, this is the standard score I had been referring to that I find to be suboptimal. If we look here, we see that there are quite a few points. I'm pausing what I'm saying so that you can see this. There are quite a few points at the bottom on the dotted line, right? This child goes down and essentially hangs down at the bottom. Now, if we actually convert all of the scores on this graph to personability scores, these are the same individuals. We see a lot more movement, okay? So, for example, these 4 points connected with a dotted line, it's this person's scores. And we see, especially with this individual who has a decline and just sort of hangs out low at the bottom, what we see here is that when we're looking at the ability scores, we see some different changes, and we actually see what's not represented down at the bottom, that this person had some sort of a little bit of an ability bump that's just sort of flatlined at the bottom with the other scoring system. Same deal here. This is a flat line. If we convert it to a personability score, we see that there was actually some degree of change that was required to earn that second point. So speaking of the Vineland and speaking of observer-reported outcomes, one of the things that, of course, is very important is gathering information about someone's functioning beyond the exam room and asking people, asking people in their lives, their family members, other people who care for them, teachers even, reviewing records written by other people to really understand someone's function and to understand it beyond this cognitive or IQ score. So adaptive function that I just showed you was one of the examples. Another piece that has been really, really important for understanding, or really importantly understood by input from caregivers, families, certainly reading records, certainly observation, is the neurobehavioral symptoms. And so I'll talk briefly about these. We have sort of classified neurobehavioral symptoms into 2 categories. There are the ones that are less obvious and the ones that are pretty observable. So when it comes to the less obvious ones, we're talking about the ones that are invisible, that you might not know what's going on with someone by just looking at them. Things like anxiety, things like trouble with focus. The observable symptoms are the kind that anyone can probably name by looking at: hyperactivity, demonstrating a lack of fear, demonstrating a very physical approach to interacting with the environment.